If you have BPD and other co-occurring conditions, this book is truly a godsend. This chapter that I'm going to get into is about BPD and depression, which I also have diagnosed depression. I know, so fun. So without further ado, let's get into it. From page 86, your depressive borderline complexity. Major depressive disorder occurs in 83% of individuals with BPD and can be a deadly co-occurrence. The combination of major depressive disorder and BPD has been found to increase the frequency and severity of S attempts. The increased risk of complex BPD due to the presence of these two conditions illustrates the need for accurate identification and treatment. Major depressive disorder symptoms are very similar to the depressive symptoms that are a part of BPD. They often include consistent low mood, low energy and volition, decreased interest in activities you once enjoyed, also known as anhedonia, disrupted sleep patterns, so insomnia or hypersomnia, weight gain or loss, a sense of worthlessness, difficulty concentrating and focusing your attention, increased ideation or self-harm behaviors, impaired social, academic, or occupational functioning, intense guilt and shame. Research shows that your outlook and interpretation of yourself, others, and circumstances are a critical factor in the prediction of major depressive disorder episodes. Major depression tends to cause greater emotional reactions to perceived environmental stressors, which increases the likelihood of experiencing a depressive disorder episode. This fits with the confusion related to your BPD. You're at a higher likelihood of perceiving and experiencing stressful events in a more intense way. Definitely true. Honking going outside, which prompts a BPD symptomatic, sometimes depressive response. Depression can occur in a single episode or be recurrent. Recurrent episodes are more common, and the presence of a single episode increases the probability of having another one in the future. A single episode is when you experience consistent and unabating depressive symptoms, such as those listed above, and it continues without a lessening of symptoms or a return to normal functioning before depressive symptoms began. You don't have to have all of the symptoms listed above, but the more you have and the longer they're present, the greater the probability you're experiencing a major depressive episode that qualifies for major depressive disorder. Recurrent episodes are much more likely to be present, such as in the story of Ray, as his depression ebbed and flowed. It's not one long, steady depressive occurrence, but depression comes and goes in episodes. That's definitely how I experience it, where it ebbs and flows. It's important to distinguish whether the depressive features are related to the fear of separation, followed by impulsive suicidal ideation, gestures, or self-H behaviors, or not. In some cases, depressive symptoms are a means to express feelings you're unable to verbally convey, such as hopelessness, anger, frustration, hatred, powerlessness, or disappointment. Maladaptive expressions are often directed at a specific person or situation and tend to be minimally attenuated by medication. Working through the situation or processing the issue with your therapist in treatment tends to produce the greatest reduction in symptoms. In a case like this, the root must be discerned. Is your suicidality and self-H a byproduct of the maladaptive need to communicate pain and to acquire a sympathetic or possibly a relationship restorative response, a BPD component? Or is it grounded in despair and hopelessness, a depressive component? This is a critical determination to make because it guides symptoms and disorder identification as well as future treatment. Discerning between your major depression and BPD. You may have been treated for major depression that was part of your surface content, but when the symptoms didn't remit, you were considered treatment resistant. This was my case. I was diagnosed major depressive disorder in my teens when I was very young, and none of the treatment that I ever did for it ever worked, and it felt very hopeless. And my doctor at the time thought that there was like no way it could be BPD because she was an idiot. Anyways, so perhaps you went through multiple therapists and services to try to gain knowledge, skills, and abilities to manage your issues related to maladaptive patterns, but had little success. Yes. You may have started to believe that you're ultimately untreatable and doomed. The lack of progress in treatment and symptom attenuation isn't due to resistance or reluctance, but to confusion regarding the full clinical picture. Telling the difference between major depression and BPD will help you gain the knowledge, recognize the skills, and acquire the abilities to build insight and strategies to manage maladaptive patterns and symptoms more effectively. The central component to distinguish major depressive disorder from a depressive episode is timing. Depressive symptoms must be present for 2 consecutive weeks or more. In contrast, a BPD depressive episode tends to include intense depression, sadness, irritability, or anxiety that typically lasts for a few hours, but in rare cases may last for more than a few days. Knowing how long the symptoms are present helps to discern whether the episode is indicative of major depressive disorder or a BPD depressive reaction. Stressor or trigger presentation is another important facet to consider. You can experience the same depressive symptoms, but if they're subsequent to an identifiable trigger or stressor, such as a loss of relationship or perceived abandonment, they're likely related to the BPD and not major depression. Once the issue pertaining to your identifiable trigger or stressor is restored, for example, after you reconcile with your loved one and no longer feel rejected, your depressive symptoms are likely to decrease or remit completely. Recall Ray's story where there was no identifiable stressor or trigger for his depressive episodes. They appeared to come and go, and they were recurrent. Ray met criteria for complex BPD that's made up of major depressive disorder and BPD. If Ray had had depressive reactions due to Maria going to the funeral, for example, and then when she returned his depressive symptoms lessened significantly or went away, that would be a strong indicator of a BPD depressive episode and not one that fits major depressive disorder. There are additional identifiers that can help you discriminate between major depressive disorder and BPD depressive reaction. Individuals with BPD tend to have symptoms that begin at an earlier age, are more likely to have co-occurring social phobia and substance abuse, and have higher rates of S attempts and self-mutilation. 2 forms of rumination, depressive and anger, have been found to be specific factors related to BPD and could be used to discern between BPD and major depression. Depressive rumination is when you continually engage in negative appraisals of yourself, your emotions, behaviors, situations, life stressors, and ability to cope, whereas anger rumination is when you repeatedly focus your attention on your angry mood and the cause of your anger. In these instances, you perseverate on depressive or angry thoughts, feelings, and images, and you find it difficult to let go. As you ruminate, you become more agitated and depressed, likely sparking a BPD symptomatic response. It's so important to be aware of the comorbidities and how BPD is such an all-encompassing condition that usually has more disorders that come with it, because otherwise we can just end up feeling crazy, powerless, defenseless, as if there's no help, when there absolutely is, and there is a path of us getting better and of us understanding ourselves more. It is not easy, but it is worth it.